We are meeting in Washington today. Yesterday was Robert Kennedy's birthday, and I took advantage of the opportunity to come down to Washington a little bit early. And I went over to Arlington National Cemetery for the first time in my life, and I walked to the Kennedy grave site. And it was a startling experience. As I'm standing there, the wind changed just the right way, and I got a full blast of the heat from the eternal flame. And something, I don't know what to call it, it was a moment. And there were white roses on Jack Kennedy and Jackie's graves. And I found out that Ethel Kennedy and some of the Kennedy family comes there every year on Robert's birthday and lays roses on the graves of the Kennedys. And there were American flags stuck into the ground as well. So it was literally a shrine. If you get a chance to take a visit there, by all means do have a look, because Kennedy's inaugural address is chiseled into the stone surrounding the gravesite. Nobody ever sees that. All the pictures are always of the eternal flame. So I sat there thinking that 50-some years ago, a man with vision was replaced by a scheming lout, for lack of a better description. I don't know how many of you have read about our former President Johnson, but he was an astoundingly corrupt, for lack of a better word, individual. And he's been succeeded by a succession of people who, let's put it mildly, don't grasp the vision that Kennedy had. So I believe we lost our soul as a country in 1963. And I don't think we're ever going to get it back unless we behave as if we never lost it. That we follow the basic principles of tell the truth. If you don't do that, you can't do anything. And then secondly, we want to share fairly. We don't want to be selfish, greedy, suffer other people to support us when it's not correct or reasonable. We want to help others. We want to try to help others have a better life than they have if they're struggling without enough resources to make a go of it themselves. We want to be thankful for the things that we have and for the opportunity to do good in people's lives, even if some of those people don't necessarily appreciate us as much as we want them to. And finally, we want to move forward. Those are the 5 basic principles I've distilled about what makes a wholesome and positive future. And I think if we pursue those goals and try to do the best we can, and enough of us pull that weight, we may actually restore the soul to the United States. That's my hope. That's what I've dedicated myself to. So with that as an introduction, let me launch into this talk about EPSDT. By way of introducing myself, I want to show you this. This is a letter that was received from Cindy Mann at the Centers for Medicare and Medicaid Services. And the red arrow points to a paragraph in it, and here's the short version. My staff has spoken with Mr. Kossor, and we learned that he has indeed developed an effective approach to serving children and adolescents with developmental disabilities, and has made the approach available to Medicaid-enrolled children through EPSDT. We agree that Mr. Kossor has a great deal of expertise and is a passionate supporter of EPSDT. Now let me do a disclaimer. The Centers for Medicare and Medicaid Services do not endorse anybody or anything. So this is not an endorsement. Think of it as an acknowledgement, because everything I've done has been sent to the CMS, including the civil rights complaint that I filed. And CMS is in the process of investigating their own internal process, some of the claims that I've made about how the EPSDT mandate is being managed in Pennsylvania. For those of you who don't know, Pennsylvania is one of the most liberal states in the nation for the implementation of EPSDT, and I'll show you why. If Pennsylvania is less than adequate in its implementation of EPSDT, the rest of the United States is at least as inadequate. So my point in filing the civil rights complaint back in 2012 was to just say, this is wrong. You can't do this to people. They're entitled to this as a civil right. I'm a licensed psychologist. I'm supposed to be aware of what people's civil rights are, and if I believe there's a violation of them, I'm supposed to report it. And the CMS and the Office for Civil Rights investigated it, and guess what? After a year of making phone calls, those people said, looks like there might be something here. So they solicited a bunch of other testimony from me and other places all over the state, and the stuff was submitted, and it's an ongoing investigation now. It's anybody's guess how that investigation is going to turn out. The CMS and or the Department of Justice and Office for Civil Rights could all conclude everything's just fine. I doubt that they'll do that. They didn't inaugurate an investigation after a year of study if they really believed everything was just fine. So I think there will be improvements made to the EPSDT implementation in Pennsylvania, and I think it'll start the process of telling the truth and sharing fairly, being thankful and helping others and moving forward like I want to have happen. So let's go forward in that regard. In January of 2001, the Department of Health and Human Services sent a letter out to state Medicaid directors, and they said, quote, "State Medicaid programs must make EPSDT early and periodic screening, diagnosis, and treatment services promptly available for any individual who is under age 21 and who is eligible for Medicaid, whether or not that individual is receiving services under an approved HCBS waiver." And earlier in 1989, the Congress said EPSDT benefits must be available to children enrolled in Medicaid, whether or not the benefits provided through that means are available through any other state program. So this stuff goes back to at least 1989. What I'm going to show you is that it actually goes back to 1967. In 1967, the EPSDT mandate was created. It was part of Medicaid. And at that time, the Congress was aware, based on reports coming back from the military, that 50% of the kids showing up at draft boards for induction into military service were ineligible because of untreated childhood illnesses. They had hearing problems, dental problems, vision problems, a host of disabilities that could have been and should have been treated. But because they weren't treated, those kids couldn't fire weapons in Vietnam. And the Congress said, this can't happen. This has to stop. 1967. Dennis Embry is an acquaintance of mine who I have an enormous respect for. He's going to be speaking tomorrow, I believe. And through the Paxis Institute, he's had a terrific exposure to all kinds of resources all over the world. And one of the things he found was that the Joint Chiefs of Staff commissioned a study about a year or so ago. And they discovered that now, 50 years after the EPSDT mandate, 75% of the boys and girls who want to go into the military can't because they're disabled due to a lack of treatment for early childhood conditions that went untreated. I mean, it's ridiculous. It's gotten worse in 50 years. A couple of years ago, I was honored at the White House as a champion of change for community-based mental health services. It was a PR thing for the Affordable Care Act. So I went down and I walked through these security lines and was ushered into one of the far wings of the White House. President Obama didn't show up, but it was the White House, you know. I was sitting in a group, you know, it must have been 200 people there, and I was honored as a champion of change. Well, yeah, I wasn't up on the rostrum talking. I was one of the crowd. So at the end of the presentation, of course, they said, does anybody have any questions? And like I have a habit of doing, I put my hand up and said, you know, I really appreciate the honor extended to me to be here, but I just wonder if any of the people here know that we have had a nationwide program of community mental health service treatment for children for 50 years. And the guy from the NIMH is up at the front and he's shaking his head, yeah. I said, I'm talking about the EPSDT mandate, and virtually nobody knows that it covers mental health treatment. I just hope that the Affordable Care Act, which incorporates a substantial body of the EPSDT mandate, will get the word out better than the EPSDT mandate has for 50 years. And I sat down. The EPSDT mandate was created in the Social Security Act. It's 42 U.S. Code of Federal Regulations, 1396 D.R.5. In the Social Security Act, it's Section 1905 R5. And this is what makes it a civil right. In that section, it says that EPSDT treatment includes such other necessary health care, diagnostic services, treatment, and other measures described in subsection A of this section. And by the way, those are the treatments that are mandatory under the Medicaid Act, subsection A. At least the first 5, and EPSDT is enumerated in there as number 4. Of this section, to correct or ameliorate, remember that word ameliorate, defects and physical and mental illnesses and conditions discovered by the screening services, whether or not such services are covered under the state plan. This is federal law. It's the Medicaid Act. And then it says below that, and I put it in red because it's really important to understand, nothing in this subchapter shall be construed as limiting providers of early and periodic screening, diagnostic, and treatment services to providers who are qualified to provide all of the items and services described in the previous sentence. Very important. If I don't prescribe or provide vision services, if all I do is provide behavioral treatment services, that's enough. I can provide just that. I don't have to provide everything else. In other words, I don't have to be a federally qualified health center. I can be an individual licensed practitioner. All I have to do is enroll in the Medicaid system in a given state, and I can oversee EPSDT-funded treatment. That's a hugely important fact, because what you'll hear, most states will say, no, we don't do that here. And what they're really saying is, we don't want independently licensed practitioners putzing around with our system. We're happy to fund the schools. We're happy to fund the state and county government agencies that we like, but we don't want independently licensed practitioners putzing around with Medicaid. Well, here you're seeing in federal law, they can. And it says, or as preventing a provider that is qualified under the plan to furnish one or more, but not all, of such items or services from being qualified to provide such items and services as part of early and periodic screening, diagnostic, and treatment services. So in the Social Security Act, every licensed practitioner of the healing arts in a given state is entitled to enroll in the Medicaid program and thereby become able to administer treatment services and bill EPSDT for them. So what's a licensed practitioner of the healing arts under scope of state law? Every state determines what such people are. Every state obviously considers a physician a licensed practitioner of the healing arts. Most states consider a psychologist to be such a practitioner. Some states don't. Some states consider licensed clinical social workers as licensed practitioners of the healing arts and not psychologists. I think the Psychology Association was asleep at the switch in those states. So the point is, your first challenge is find out who is a licensed practitioner of the healing arts under scope of state law in your state. Those people, because of their autonomous and independent status, may be more courageous in terms of challenging the status quo about EPSDT funding. Continuing in the 42 Code of Federal Regulations, this is Chapter 4, Part 440.130. Again, it's the Social Security Act. And in this section, this is Section A, Section 13 of the Social Security Act, it describes explicitly what EPSDT services are. And they consist of diagnostic services. Now you see the word recommended by, bold-faced. I highlighted there because it's an important distinction. Preventive services, it says provided by. Let me make sure you understand the distinction. Diagnostic services that are recommended by a physician or licensed practitioner of the healing arts, that would be me. I'm a licensed practitioner in Pennsylvania of the healing arts. So I can recommend diagnostic services, and staff under my scope of practice can actually do them. I can supervise people who are collecting data about a child, who are, under my scope of practice, rendering treatment. Now, according to this, preventive services says services provided by a physician. That was changed in the Affordable Care Act to also say recommended by. And then finally, rehabilitative services recommended by a physician or other licensed practitioner. This is the part of the Social Security Act and the Medicaid Act that lets me supervise a person with a bachelor's degree who goes into the child's home, works with the child, perhaps works with the siblings as well, but having the one identified child as the recipient of treatment. And if they go into the school, my staff can help the other children who also are involved with that child's life to treat that child more benignly. And again, like I said, repel the more pestilential influences that are out to hurt the child. So my staff can do this, and it can be billed under EPSDT because it is a rehabilitative service. It is in fact called Behavioral Health Rehabilitation Services. Now, Pennsylvania went off the rails when it first created BHRS, and they started calling it wraparound. Have you heard about wraparound, right? Okay, everybody has. Do you all understand that wraparound is not a substitute for treatment? It is a way of organizing and managing treatment, but it is not in any way, shape, or form a substitute for it. A lot of people don't get that. They keep talking about high-fidelity wraparound as if that's all that's necessary. You'll see in a short time that if you have wraparound and that's it, and there's no active treatment in that cup, the wraparound cup is empty, and you can wear it for a hat for all the good it's going to do. There are three key concepts I want you to take from this presentation. The first is, and this is according to federal law, Chapter 4, 42 Code of Federal Regulations, Part 438.210. Each service must be sufficient in amount, duration, and scope to reasonably achieve the purpose for which it was furnished. Period. Now, it's a simple question. Who determines the purpose for which a service was furnished? Me who sees the child face to face, makes eye contact, interviews the parent, talks to the teacher, makes behavioral observations, and does it all, right? Or some character with a license who's working for an insurance company who never sees the kid, who reads my report. Can that person possibly determine the purpose for which the treatment I prescribed is furnished? No. Of course not. There hasn't been a federal court in 50 years that says that character can trump me. Not ever. Yet that's managed care. So when I have to submit, because of a waiver that was passed after the EPSDT mandate, when I have to submit my evaluation report to an insurance company and have somebody with a comparable degree or whatever review it, I have to do that. And insurance companies are accustomed to having godlike authority to say, no, you can't. Right? That's what they do for a living. That's why they exist. What about the EPSDT mandate? A child is entitled to treatment that is sufficient in amount, duration, and scope to reasonably achieve the purpose for which it was furnished. How about the first purpose is to prevent the worsening of the child's condition? How about the second purpose is to treat the child's condition, to ameliorate it? And how about the third purpose, for which a treatment is prescribed, by me at least, is to help the child maintain their functioning comparable to other kids of the same age? If I have all three of those purposes for which I'm prescribing it, how in God's name can an insurance company person say, tut tut, they don't need it? Can they? This is what I raised in my civil rights complaint. And you can tell why it's under study now, right? Secondly, EPSDT services must be provided to disabled children enrolled in Medicaid, whether or not the services are provided for in any state plan. That was the Omnibus Budget Reconciliation Act of 1989. It's an act of Congress that guaranteed access to EPSDT services. And finally, Medicaid, not the school, must pay for covered services to a child, especially if funding is in dispute. Medicaid is the payer of first resort for services in schools. Get that loud and clear. Yeah?
Okay, that's really helpful to me. I have a couple of questions. I'm from Mississippi, and we have a Department of Justice findings pending about a lot of things, including EPSDT. And I just want you to know that what I understand our state to say is we provide those same services, we just don't do it through EPSDT, and I don't think the services are provided. So that's one question. But my other question, and this answers it in part, is looking at these services in the school system. One thing, and they're very sincere, one thing that other advocates and parent groups in my state say is that under IDEA, of course, these services are supposed to, some of these services are supposed to be covered. And are we letting the schools off the hook by using Medicaid? And is it a violation of families' privacy when schools are asking for the information so that they can bill Medicaid? So however that fits in your talk.
Okay, that's what we call a mouthful, isn't it? All right. But everything you've talked about will be covered in this presentation. Let's just first start out by, yeah, question.
One more thing. I'm from California. We don't have Medicaid.
Yes, you do.
We have Medi-Cal.
It's the same thing. It's Medi-Cal is what they call it in California.
So, I gotta say, I've had some limited experience working in the schools now, and I've never seen any discussion about EPSDT.
Why would they talk to you about it? It's a private deal. They don't have to talk to you about it.
Under what department in the schools? Would it be managed by the Department of Education at the state level, or does it come down to
It all trickles down to the school level. And let me just tell you how it works in Pennsylvania. And to some extent, the same processes were afoot in California with the same company. Medicaid funds services in schools. Every school district can enroll in Medicaid as a provider of services. Every school can be a provider. Understand that. So now not only are you a provider of education services, but you're a Medicaid enrolled service provider. And you've got a number within your state government to bill under. Most states implemented a system 20 years ago that said, okay, look, we're going to help the schools manage this Medicaid billing stuff because really it's a different world. So we're going to set up one company in each state that has the responsibility of processing Medicaid payments submitted by schools. In Pennsylvania, it was Leader Services. They lost the contract recently and were replaced by another company. I think Leader may have also had the contract for California. In any case, Leader Services would set up accounts for each individual school district. There were 501 in Pennsylvania at the time, and within 3 years of the establishment of this school-based access program, I think 499 of them had already signed up for it. So it's a wildly successful program. So the way it works is the school collects data for service delivery. If the guidance counselor sees a child who's got an IEP, guess what? That kid's got enrollment in Medicaid because he's got an IEP. So every time the guidance counselor bills for an hour of time with that child, either in an IEP meeting, a counseling session, a phone contact with the parents, so you get a look at what's going on here. The guidance counselor's salary, let me finish this thought just for a sec. The guidance counselor's salary is added up with all of the perks, vacation time, car allowance, phone allowance, and it's all added up. So now the guidance counselor's hourly pay rate is $65, right? It just keeps ratcheting up. So let's say $65 is the counselor's hourly rate. And the Medicaid reimbursement rate at the federal level in that state is 50%. It's never less than 50%. In Arizona, it's 75, I think. So 50% of the guidance counselor's added up salary can be billed through Leader Services or some other company to Medicaid. And that money is deposited in an account at Leader or wherever. And then the school makes a withdrawal from that account to supplement its special education budget. Now, in some school districts, that money is not on the books. For whatever reason, they're apparently allowed to have it, the equivalent of a slush fund, I think, would be an apropos term. They bill Medicaid through this organization. They make withdrawals. It goes into their budget. They use it to fund anything related to special education, whether they need more computers or the principal and a few of his buds need to go to Vegas for a week for training. As long as it's in the special ed budget, the schools tap the Medicaid fund. $140 million in 2012, I think, in Pennsylvania. And it's been going up every year for a decade or more. Every single state in the nation is tapping Medicaid for $100 million or more every year. That's $50 billion of Medicaid money flowing into schools over the course of the last decade. So that's how it works. That's the school-based access program.
I'm from Guam and we're a territory. How does this play out?
It plays out in Guam. You're a territory. You cash in too. Katie Beckett. Katie Beckett was a child with a severe disability. And her parents said, look, it'll cost you this much to treat Katie in an institution. We'll do it at home for this much. What do you say? And the state said, That's a deal. Okay. And they created what's called a waiver, a Katie Beckett waiver. So what you have to understand is there's a difference between waivers and EPSDT. And I'm becoming famous for this. This is a box of breath mints. There's 50 of them in there, and they're all free. But they're going to run out. There's a waiting list, and when they're gone, they're gone. And the states all want you to take this waiver money and use it. It's free. It's yours. Please. EPSDT, on the other hand, is like a wallet full of credit cards with an unlimited balance. And I'm not kidding about unlimited, and I'll show you the proof of that. It has the child's name on it, and that is money that's available to treat the child in any kind of ways imaginable as long as they're enrolled in Medicaid and they have a disability. So some states require you to go through a waiver in order to have access to Medicaid enrollment, but you don't want a waiver. Don't settle for a waiver. You want to look at the state's Medicaid plan and ask the state authorities, talk to the governor's office and say, I want to know what our state's rule is for enrollment in Medicaid. Now the Kaiser Family Foundation publishes a list of states that have what's called medically necessary eligibility. Medically necessary means you have a disability and you're entitled to enrollment in Medicaid because of that disability. You're a family of one. You're 7 years old. What's your income? I guarantee it's below the federal poverty level unless you have a big trust. Oh. Lawyers who have recommended to parents of disabled kids, you need to set up a trust for your child, they have literally destroyed the child's ability to access Medicaid funding. If a child has income through a trust or some other means that pushes them above the federal poverty level, they're ineligible to tap Medicaid. That's a tragedy. So fix that to the extent you can. Because once you have a level of income below the federal poverty level, and you're a child with a disability, in 36 states, you can enroll in Medicaid as a family of one. And your income counts, not your family's income. They did away with asset tests many years ago. So it doesn't matter how many cars your parents own or, the size of the television screen or anything like that. It simply matters what your income is, and if you're a family of one, you qualify if you're a child and your income's under federal poverty.
I'm sorry, but our state Medicaid has told us family of one no longer exists because of ACA.
The Affordable Care Act?
Yes, yes.
Okay, I'm not an attorney. I'm not given legal advice, and perhaps there is some arcane thing within there that they may be telling the truth. I can't tell. But I do know that federal law says, like it says on the screen, the treatment has to be sufficient in amount, duration, and scope to reasonably achieve the purpose for which it's furnished. That purpose is determined by a licensed practitioner of the healing arts who prescribes the treatment, and any child enrolled in Medicaid through any means whatsoever has to have access to EPSDT funding on that basis. See, there's a couple of ways of enrolling in Medicaid, just two. There is medically needy and there is categorically needy. Categorically needy means your income is below the federal poverty level and you are categorically eligible for Medicaid on that basis. Not only you, but every member of your family, because you're all below the federal poverty level. But the medically needy category exists. It exists in all 50 states. They could adopt it. They don't have to. Don't forget, the 10th Amendment prohibits the federal government from interfering in the states unless they are mandated to. We can't have slavery in the United States because it's against the Constitution. But what stops us from having Medicaid eligibility for all disabled children without regard to family income in all 50 states? Let's look at the connection between Medicaid and education law as specified in federal law. Under the Medicaid Act, the Social Security Act, 42 U.S. Code of Federal Regulations, Section 1396B, subsection C, it says that Medicaid, not the school system, must pay for covered services to a child, even when these services have been found necessary and included in a child's individual education plan or individual family service plan. And Medicaid law shall not restrict payment for covered services because such services are included in an IEP or IFSP. That's clear as day, right? There's no question about that. Now let's look at the IDEA and IDEIA, the Individuals with Disabilities Education Act. 20 U.S. Code of Federal Regulations, 1412A, subsection 12, capital A, subsection little I. I mean, it's ridiculous. How deeply is this stuff hidden? It says, if any public agency other than the educational agency is responsible for providing services under federal and state law, such public agency should fulfill that responsibility. Medicaid is a public agency. Medicaid funds EPSDT. And wait for it, when you see all of the benefits that EPSDT covers, you'll realize that Medicaid has to cover all of those services in a school. A school is obligated to provide FAPE, a free appropriate public education for children who are disabled. It goes without saying. That goes back to 1975, the Individuals with Disabilities Education Act. It was updated in 2004, IDEIA, and one of the biggest changes they made there is the entitlement to due process that was granted to parents in 1975 was amended. And now, unless you have a lawyer with you in a due process hearing, you can't object to the presentation of the school district's lawyer or exclude evidence from the due process. You literally have to be a lawyer. So now in 2004, IDEIA blocks rights that parents were given in 1975. That's one of the biggest changes in it. But on the screen right now is a letter, actually it was a memo, sent from the Department of Public Welfare, which is the state Medicaid agency in Pennsylvania. And that letter was sent to the Department of Education in Pennsylvania. And this is December 28th, 2009. And in it, it says, quote, and the reason for this memo was this. The schools were complaining because parents were reluctant to sign the paper that got their kids into Medicaid because they were afraid it would cut off their benefits elsewhere. Now don't forget, Medicaid's a keg with two taps. The school tap, 100 million plus a year, and then the tap coming out the top that parents can access for the treatment of their children's needs. So with the two taps going, the schools were saying, please, just sign this so we can run Medicaid into our school district. And the parents were saying, no, I don't want to do that for a variety of reasons. So the Department of Public Welfare sent this letter to the Department of Education, and I'll quote, the health-related services a student receives through the school-based access program are separate and apart from the MA, that's Medicaid or Medical Assistance Services, a child receives outside of the school setting. And they go on to say, additionally, there is no cap or limit on the total amount of money that may be paid by the MA program for school-based access services or medical assistance services that the MA-eligible child may receive. This is absolutely clear as day, right? And this is nothing new. This is simply a restatement of federal law. So there you have it. It's an unlimited fund of money flowing into schools, and it's also an unlimited funding of money, just like the wallet full of credit cards I talked about, funneling into parents who are aware that this is a civil right for disabled children who are enrolled in Medicaid. This is the definition in Pennsylvania of what is medically necessary treatment. And every state has its own definition. That's important. You need to look up what the state's definition of medically necessary treatment is in your state. Some states specify that the treatment has to be, quote, cost effective. Every single time in 50 years that that clause has been challenged in federal court, it's been thrown out. You can't say it's too expensive. Let me just take a poll. Have any of you heard about hyperbaric oxygen therapy, HBOT? Okay, some of you have. Some people are absolute advocates for it because anecdotally it's helped some kids. Great. Anecdotal reports are established as standards of proof in loads of places all over the world. So you got a couple of kids who got better from it. Is that treatment, which is clearly experimental and clearly uncertain as to whether or not it's going to be effective, is that treatment fundable under EPSDT? Does anybody think it's not? Good for you. It is fundable under EPSDT. The Sixth Circuit Federal Court in Georgia reviewed a case where HBOT was used to treat a child. And it helped the child. There was data taken. Here's her behavior before. Here's her behavior during. Here's her behavior after. And when we terminated the services, the HBOT treatment, her behavior got worse. Therefore, Your Honor, the services are necessary under EPSDT. Notice the argument, well, that's experimental, we can't do that. That's not part of the equation. It can be an experimental treatment. There's nothing in federal law that blocks experimental treatments. States might try to enact those kinds of blocks or barriers, but if it's challenged in federal court, they've been knocked down. So in Pennsylvania, the definition of medically necessary treatment is a service item, procedure, or level of care that is necessary for the proper treatment or management of an illness, injury, or disability is one that, and they have three possibilities, any one of which establishes the medical necessity of that treatment, service, or procedure. First, the treatment, service, or procedure will, or is reasonably expected to, prevent the onset of an illness, condition, injury, or disability. Okay, so it'll prevent it. That's one. Secondly, it will, or it is reasonably expected to, reduce or ameliorate. Ameliorate just means make less. The physical, mental, or developmental effects of an illness, condition, injury, or disability, or it will assist the recipient to achieve or maintain maximum functional capacity in performing daily activities, taking into account both the functional capacity of the recipient and those functional capacities that are appropriate for recipients of the same age. So you see, any one of those makes a service, treatment, or procedure medically necessary in Pennsylvania. So how in God's name does an insurance company person conclude that a treatment I prescribe specifically for these purposes to be medically unnecessary? It's just inconceivable. And this was published in the Pennsylvania statutes in April of 2007. So we're looking at like a long history. And this was published as a clarification of a policy that was existing in Pennsylvania as early as 1989. So when the state Medicaid agencies and the insurance companies and the county governments started chiseling away at EPSDT benefits, the State Department of Public Welfare published this clarification to make it crystal clear that this is the definition of medically necessary treatment in Pennsylvania. Before we go into part 2, putting BHRS in a wraparound cup, I'm going to back up and I'm going to go through the EPSDT list of services. These are all covered services in a school because they are specifically enumerated in the EPSDT mandate since 1967. Look at it. Treatment and prevention. Now, the slide says treatment and prevention. Prevention is actually the primary purpose of EPSDT. So the slide should say prevention and treatment. Physical, speech, and related therapies, hearing services, eye exams, eyeglasses, durable medical equipment, home, residential, and inpatient care, dental care, and other services, including mental health care.
I have a question. How is a child determined to have a disability?
Terrific. I'm glad you asked that. It's very, very, very simple. A licensed practitioner of the healing arts under scope of state law looks at the child and says, you have a disability.
So if a child has a mental health diagnosis, then they have a disability?
Absolutely. Now, there is a blue book that the Social Security Administration publishes. It's called the Blue Book of Disabilities, right? It's available online. I think there are 11 or 12 disabilities in the Blue Book. Autism, right there. ADHD, right there. And 10 others that identify disabilities that are common in childhood. If a licensed practitioner, and that can be a social worker in some states, says, you've got a disability, I'm identifying it as this, that makes that child entitled to EPSDT funding if they are eligible for enrollment in Medicaid. Any foster child is automatically eligible for Medicaid. Some states exclude children because of family income, but not foster children.
I may have missed this, but because I came in late, but did you ever give a list of the 14 states where it is?
You know what I didn't, and let me tell you this. If you go to the website of the Institute for Behavior Change, www.ibc-pa.org, and you go to the Resources for Parents tab.
I can read them out.
You got them? You can call them up?
Yeah.
Sure, go ahead.
There's Arkansas, California, Connecticut, the District of Columbia, Florida, Georgia, Hawaii. Are these four? This looks like more than 14.
If your state is listed in that list, it is a medically needy state. So a child can enroll in Medicaid regardless of family income if they are on that list.
Okay. So Georgia, Hawaii, Illinois, Iowa, Kansas, Kentucky, Louisiana, Maine, Maryland, Massachusetts, Michigan, Minnesota, Montana, Nebraska, New Hampshire, New Jersey, New York, North Carolina, North Dakota, Pennsylvania, Tennessee, Texas, Utah, Vermont, Virginia, Washington, West Virginia, and Wisconsin.
Big list, huh? Okay, the other thing is Puerto Rico used to be on that list. It was taken off, I think, in 2012. Tennessee used to be on that list, then they took it off, then they put it back. Okay, so it goes back and forth. You need to talk to your state Medicaid agency to make sure that you have, quote, medically needy eligibility in your state.
State Medicaid what?
State Medicaid agency. In Pennsylvania, it's the Department of Public Welfare. Whoever the state Medicaid agency is, the best way to find out, call the governor's office. They usually know. Yeah.
Like we have TennCare in Tennessee.
Yeah.
And like, it doesn't pay for the child's full eye exam and eyeglasses. there leaves maybe sometimes an $8 balance or maybe a $20 balance. Would this cover the remaining of it?
TennCare is Tennessee's version of Medicaid, just like Medi-Cal is California's version. According to EPSDT, those services on that list here have to be covered. That doesn't mean covered in part. It means covered.
100%.
Okay, and this is where we get into those, you know, the politicians with less vision than Kennedy is all I can say. You know, I don't know how else to describe it. Politicians can do good or ill. You know, not all of them do uniform good.
We have children in our school district that, like, we have to get individual sponsors to pay for eyeglasses.
Of course, you got to beg, borrow, and steal, scrape to get money together from the Lions Club, right? Or the teachers shelling out, throwing a couple of bucks at it. What would you have to do to get the state Medicaid agency to fund this? The answer is, don't go to the Department of Developmental Disabilities or the Department of We Don't Pay for Nothing. You know, don't waste your time. You want to find out who's in charge of EPSDT. I had a terrific experience with some people in a state that I won't mention the name of. I did one of these talks in their state, and they said, this is great, we're going to go do that. They went to 4 different state entities, and each time were told, no, we don't do that here. And when they finally figured out which one handled EPSDT, they said, yeah, okay, just submit your bill here. Done. EPSDT is like ice cream. Every single state has its version of ice cream. Every state. Some of them put nuts in it, some of them put lots of nuts in it, but it's all ice cream. You have to find out where the refrigerated cabinet is that stores the ice cream. And it's not in a room that's labeled ice cream. It's in a room with no name on it. And the only people who know what's in that room are the people who are responsible for the ice cream. So if you talk to the Developmental Disability Department, if the ice cream isn't stored there, you have to talk to the governor's office and say, hey, I know about EPSDT. Tell them you want to talk to the person in the state government who's in charge of EPSDT. And don't take no for an answer. You don't want the waiver. You want EPSDT.
I have a question. My husband and I are foster adopted parents, and one of the children that we adopted has a severe skin condition. Anyways, he sees a doctor on a regular basis for treatment, and the doctor wanted us to get a light box for our house so that he could use this as part of his treatment. And Medicaid said, no, we won't pay for it. And so we would have to pay for it out of our pocket, which is like $10,000. So do I call and talk to the person in charge, or does the doctor?
We're going to get at a strategy of what you can do shortly.
Okay.
All right. Yeah.
Someone said there was a list going around. I want to make sure my name's on that list.
Okay. In the back, next to, look, you'll see brochures, one yellow or white, one purple. In the back there, there's a list. Just print your email address on it. Please do it legibly so I can not fail to send this. For those of you who may not know, I am recording this. I'm doing an audio-visual recording, and I'll edit it. I'll take out all the sneezes and whatever, and I will deliver it to you, or at least a link to it, and the PowerPoint notes pages as well. So you'll have everything that you could possibly need to make life unpleasant for the EPSDT czar in your state. And I'm not kidding about, I love doing this. This is what I've dedicated my life to. And I'll support anybody I can in any way I can through email or phone calls. And check out the IBC website. There are loads of resources there. And there's also another website I want to draw to your attention. This is called Treatment Plans That Worked, ED, treatmentplans.worked.com. And if you go to that website, you're going to see treatment plans that were actually used and funded by EPSDT in Pennsylvania with the data that shows they were effective. There's 576 of them there. You'll find a dozen or more treatment plans for girls under the age of 9 who've got autism spectrum disorder symptoms and were biting or whatever else. And you'll have a dozen plans that were funded under EPSDT. Here's the strategy. You have your licensed professional access those plans for the whopping fee of $65. They have the plans now. They can examine a child, diagnose a condition, and write a treatment plan using the foundation from treatmentplans.work.com to create a treatment plan specifically for that child. And they write it up on a piece of paper and they give it to the parent, and the parent takes that to the state Medicaid agency and says, I want this funded for my child under EPSDT, just like it was funded for this kid and all of these other kids in Pennsylvania. At that point, the state Medicaid agency can say, no, we don't do that here. And if they do that, that fast, they have violated the child's civil rights. Because a child in every state who's enrolled in Medicaid or even eligible for Medicaid enrollment is entitled to treatment that is sufficient in amount, duration, and scope to reasonably achieve the purpose for which it is furnished. Now, if you have a local practitioner who's an enrolled practitioner of the healing arts who's prescribing a treatment to prevent the worsening of a condition or to ameliorate the effects of a condition or to maintain functioning or health, all three at once, now chances are that prescription meets the definition of medical necessity in your state. And now the parents can make it really uncomfortable for the EPSDT czar if they decide not to fund that kid's treatment. All right, we're going to slip through now into the subject of putting BHRS, Behavioral Health Rehabilitation Services, into a wraparound cup. And in my estimation, that is the most effective way to put treatment into a child's life. As I said before, if the wraparound cup does not have substantive evidence-based treatment inside it, you can wear it for a hat. It's not going to be helpful, or nearly as helpful than if it has a bona fide treatment program inside. I want to clarify what we mean by wraparound and what wraparound is not. This was a statement of testimony given by Eric Bruns, who is the co-coordinator of the National Wraparound Initiative, in a lawsuit, this is federal court, JKV Eden, that was held in Arizona regarding the Medicaid EPSDT program there. And Eric says, quote, the behavioral health system in Arizona uses the term, quote, child and family team process, end quote, to refer to the process of planning and delivering services through a child and family team. This is the process to which I refer when I use the term wraparound process. So immediately you have to ask the question, what services? What is he talking about? He goes on to say that an effective children's mental health system must provide quality behavioral health services, good for you, I'm on there, including good care management, e.g. through a child and family team and intensive case management, okay. It must also have a method for ensuring that interventions are leading to improved outcomes for children. Well, first of all, care management is not treatment. Intensive case management is not treatment, and ensuring that interventions are leading to improved outcomes is not treatment. This is a section from the National Wraparound Initiative's Wraparound Fidelity Index version 4. This is a tool that's used by the NWI or other practitioners to determine the extent to which their implementation of wraparound qualifies as, quote, high fidelity. Now, when I did this with the Institute's staff, we took the NWI Wraparound Fidelity Index and we surveyed our clients. We have about 100 clients now in 4 Pennsylvania counties. And we went through the staff and said, look, score this thing. Well, we came up just almost off the charts in terms of the wraparound initiative's preferences for wraparound fidelity. The one area where our implementation of services didn't quite cut it, according to the National Wraparound Initiative, and this is really tragic. The NWI Wraparound Fidelity Index expects that the parent and the professionals have equal input in the delivery of treatment. What? Unless my staff have a higher level of expertise than the parents, they have no business being at a meeting. They're supposed to know more about the treatment of these disabilities than the parents do. Now wait a minute, that doesn't mean we dictate to the parents and tell them what has to be. We work with them, and they come up to the level we want to recommend, or we don't work with them. The parents don't dictate to us what we must do to satisfy them. We're licensed professionals. We prescribe a treatment program. If the parents want to do it, we'll do it. If the parents don't want to do it, we won't do it. That's all there is to it. That's a professional, ethical practice of a profession. Do you see where I get into trouble with the National Wraparound Initiative? Some people are sitting in the audience and they're looking like, well, wait a minute, this guy thinks he's a god. No. I know what I'm doing. I've been at this for 30 years. My staff have been trained, experienced, etc. That doesn't make them gods. It doesn't make them infallible or omnipotent. But they have a standard level of expertise. If the parent doesn't want it, they don't have to take it. That's how you do it professionally. Any questions about that? Okay. The Wraparound Fidelity Index focuses on fidelity to the wraparound process. The Wraparound Fidelity Index is not designed to measure the adequacy of the behavioral health services in a child's behavioral health system or outcomes for children receiving those services. You can't make it any more explicit than this. The wraparound process is not treatment. It is like a cup within which treatment can and I think should be delivered. It is an indispensable model, and we follow it to the extent we possibly can. And so should everybody else, because it really does facilitate dialogue, conversation, and you don't want to deal with a treatment provider that is impervious to input. For God's sake, that violates the basic principle of share fairly, right? You have to share fairly. You have to be welcoming of input from the family, because honestly, they know the child way better than you ever will, no matter how skilled you are. But just because they know the child doesn't mean they can dictate what the child must receive. There has to be a barrier there. You have to try to collaborate. You don't want to be colluded or co-opted or these other perverse things that can happen when a county or an insurance company oversteps their bounds in the delivery of a kid's treatment program. Something else you got to understand. This is Russell Barkley on his website. For those of you who don't know, Russell Barkley is the world's leading authority in the treatment of ADD and ADHD. And this is a quote from Russell's website. The treatment of ADHD requires a comprehensive behavioral, psychological, educational, and sometimes medical evaluation, followed by education of the individual or their family members as to the nature of the disorder and the methods proven to assist with its management. Good for you, Russell. Do we hear medicine is the treatment of choice for ADHD to the exclusion of all other treatments? Of course not. He's sane. How many doctors believe, based on a study that was outed on the front page of the New York Times, the study that doctors have been citing for a decade or more, saying that medicine, Ritalin, Cylert, various other medicines, is the treatment of choice for ADHD. That study was not truthful. And doctors who say that treatment of ADHD requires medication are purely and simply wrong. What condition exists between 8 a.m. and 3 p.m. Monday through Friday? That's a condition, right? School's the condition, right? Yeah.
In Arkansas last year, we started episodes of care. The first episode of care we rolled out was ADHD. And according to the APA and other folks that we researched, our first line of attack and only line of attack is medicine.
Of course. If you're a hammer, does everything look like a nail? Psychiatrists are hammers. They're real good about medicine. Do they know about psychological support? Maybe. But their primary thing is they're a doctor, and they were taught how to prescribe medicine correctly. But if they're using the wrong references, if they're using studies that were falsified as the basis for their prescribing practices, there's something askew. This is a section from the purple brochure that describes what we do in Pennsylvania to deliver behavioral health rehabilitation services. You can think of it like a pyramid. At the top of the pyramid is a licensed psychologist. Some states allow social workers or counselors to have that authority. They are the licensed practitioner of the healing arts. Under their scope of practice in Pennsylvania, they can supervise up to 3 full-time equivalents of master's level mental health professionals. Those are mobile therapists or behavior specialists. They have master's degrees, they've got extensive training, and they're not necessarily licensed, although they can be as a counselor or as a behavior specialist, but they operate under the scope of practice of the psychologist. And they get supervision directly from the psychologist to make sure that they're aware of the EPSDT requirements, the Medicaid laws, etc., so that they're operating within the parameters that they're allowed to operate within. Those master's level mental health professionals can each supervise up to 9 full-time equivalents of bachelor's level people. So I supervise my 3, which is 120 clock hours, and each of them supervise 9. That's 360 hours a week. And it's more than 9 people, it's 360 hours. Not everybody's doing 30 hours a week. You see how it works? Or 40 hours a week? So it winds up being a force multiplier model that is colossal. I'm working with 20 families with my staff. Those kids are getting treatment that is working. It's in their home, in their school, working with siblings, working with peers, working with teachers, working with parents. It's the only way to deliver treatment to children that I think is viable. Tell your friends, if you get a licensed psychologist or even a physician, a pediatrician, how often do pediatricians prescribe behavioral treatment programs to deal with toileting or feeding? For God's sake, they do that all the time. Now you're going to have the pediatrician prescribe a treatment program to deal with biting or toileting or whatever. But instead of having the parents implement it, you bring in an outside treatment provider who's trained and experienced and supervised in the delivery of behavioral treatment doing the treatment program just like I would write if I was doing it, and supervising it and managing it. And now we have a way of delivering effective treatment throughout the world by one psychologist responsible for 30 or more providers. In our practice, we do a BHRS continuation checklist, and this is something recommended by the American Psychological Association. You have to decide, does it make sense to continue somebody in treatment? They may not be a viable candidate for treatment. Well, first of all, does the client think you have a good working relationship? Without that, pretty much you're not going to do anything. Do you and your client share the same treatment goals? Does the client report any progress? For the love of God, if there's no progress, how can you, what are you going to watch the ship sink? Is this your job? You're a spectator? So we do this at the end of every treatment program, which goes for 4 months. It is legal in Pennsylvania to prescribe treatment for a child with autism for a year. And I'm sorry, that's a little bit like, look, he ain't going to get better. You know it, we know it. Just don't bother me for a year. But come in and do what you can. Are you kidding? This was the Autism Society and all the big advocate groups that pushed for this as though it's a boon to parents. Well, let me give you the true story. I go to the kids' school. I go to the kids' home to do an assessment. Nobody ever comes to my office, and that's the right way to do an assessment. You go to the school, you sit and watch, you engage with the child for a little while. I do this thing with thumb wrestling. Do you ever do that? You're trying to put their thumb down, they're trying to put yours down. That's a terrific way to gauge reciprocity in a child. It's not just, tell me about your mother. No, look here. You know? Okay, so you get what I'm saying. It's an active process in life. We don't intervene on kids. We intervene in their lives. That's what my staff do. It's what I do. And then we check with the parents at the end of a treatment period for 4 months. Okay, how you think it's going? Are we on the same page? And if they're not, if the parents are saying, you know, you need to be a better supervisor of my child because frankly I've got more important things to do, right? Or if a teacher cops that attitude, we give them a real clear warning. We're not going to stand here and be treated like a gardener without a green card. We're here to help your child, but we're not here to fix him without any involvement on your part. So there has to be collaboration. People who are desperate are going to do desperate things. And sometimes they have children and their children get traumatized. So what we have to face is, what does trauma do to a kid with ADHD? What does it do to his treatment program? He's got ADHD. This is a 3-month treatment program. Well, he watched his father kill his mother. Now we're talking about a treatment program that it's going to take an awful lot longer because he doesn't trust anybody, etc., etc., etc. So you all understand trauma necessarily expands the need for treatment. So the insurance companies routinely say, you have to do a trauma assessment. Okay, and we do, and now they ignore it. This is supposed to be a time-limited treatment process. Wait a minute, the federal law says it's birth to 21. Where do you get time-limited? Oh, that's your bright idea and your interpretation of federal law. Guess what? The federal judges don't agree with you. And the state can get away with it until somebody tells them to stop. When I called the Office for Civil Rights and I confirmed that I'm obligated under federal law to make this complaint because I know civil rights are violated, I said, how many other providers in the history of time have ever done that? And the woman chuckled and she said, it never happens. The only people who ever filed civil rights complaints are parents whose civil rights have been violated. I said, well, why is that? You know, you could hear the nodding, you know, the loll of the head, like, oh my God, could he be that stupid? You don't bite the hand that feeds you, and you don't bite it off up to the elbow, right? I don't think I'm doing that. I'm not biting a hand that feeds me. I'm biting a hand that's trying to pull food away from me that I'm entitled to get to help children. So think about that. All of the people who think, I better not say anything, I better not rock the boat, I better hope that some lawyer is going to file a suit in federal court and save us, right? Anybody who thinks that's going to happen, first of all, they got to think about it. It's not going to happen because the advocacy organizations all have, to some extent, funding from insurance companies and county and state governments, and there's no reason to think that they will rock the boat. That's not what they do. The reason they exist is because they're in there rowing right along with them, right? The only entity that can step in and say, you can't do this anymore, is the Office for Civil Rights. One of the things I teach my staff is sensitivity, and we talk about privacy and dignity. When you have privacy, you tend to have self-security, safety, and freedom from embarrassment. When you do not have privacy, you get paranoid, defensive, and behave in an aggressive and withdrawn manner. It's just self-protection. By the same token, if you have dignity in your life, you tend to show self-esteem, have satisfaction in your life, a hopeful and optimistic outlook, and cooperative behavior, right? Goes without saying. If you don't have dignity, you're going to display self-loathing, you'll be dissatisfied with life, develop a hopeless and pessimistic outlook, and display uncooperative behavior to the extent that you can. So what's the simplest understanding? If you see paranoia, defensiveness, aggressive withdrawal, improve the kid's privacy. Look there and figure out how their privacy is being destroyed unnecessarily. If you see uncooperative behavior, hopelessness and pessimism, possibly suicidal ideation, dissatisfaction with life and self-loathing, look at dignity. How have you supported or allowed their dignity to be undermined? These are fundamental realities that go way beyond behavior mod, right? And certainly not behavior mod with a German accent, right? We don't do that. You've all heard about applied behavior analysis. Applied behavior analysis is the, quote, treatment of choice for kids on the autism spectrum. ABA is something we routinely do because ABA, if you look at the literal definition of it, means that you're taking outcome data and you're using it on an ongoing basis to inform the treatment process. That's applied behavior analysis. It's not a treatment modality unto itself. It's an approach to treatment. And I've been doing ABA for kids on the autism spectrum for 20 years, funded by EPSDT. So the bottom line is, one of the things that we have got to face in the behavioral health world is that there is a lexicon of terminology that some people are appropriating terms as having arcane meanings that only they can understand, and ABA is one of those. ABA is the scientific application of behavioral treatment technology and philosophy and methodology to the remediation of behavior that is socially significant. That's really all it is. So if you're implementing a behavioral treatment program and taking outcome data and using that data to inform the delivery of treatment on an ongoing basis, you're doing applied behavior analysis. In life, we have performance and reinforcement grids. In children's lives, they have performance grids, and their reinforcement grid only rewards them at the end of the school day. You get your green light, your yellow light, and your red light, and if you were green all day, you get a special 15 minutes in front of the computer between 2:40 and 2:50. Or some idiotic thing like that. This is what it should look like. If you have a high level of demand in the performance grid, there should be in the reinforcement grid at the same time or shortly thereafter a payoff. something that you get in exchange for your display of tolerance, patience, competence, right? This makes sense. This is how we organize our lives. We're not going to wait until the end of the week to get our paycheck. Well, maybe 2 weeks. But in between time, we get some intrinsic gratification out of our lives. Children with behavioral disabilities, they need much more frequent reinforcement. And when you see a parent or a teacher who says, I'm not going to bribe him, he should do it just because he wants to. You know, you can imagine the black pointed hat. Huh?
I had that teacher with my child.
We've all met them, and bless their hearts, we hope they get what they deserve, right? Yeah, and here's the secret. They will. They will. Trust that. Karma exists. But in the meantime, we have to cope with those people. So how do you cope with them? You say, listen, there's a difference between bribery and reinforcement. What's a bribe? A bribe is something I give you before you act to do something bad. Reinforcement is something I give you after you've done good, not bad. Bribe and, you know, they're wholly different things. So schools do what they do. They don't do it intentionally for the most part. And not all teachers are evil, but they are caught up in an evil system that just grinds children up. And the whole point is, we are a family of humanity. We have to cope with the disabilities that exist among us, try to remediate them, try to support the people who need help, and don't deny it. This movement that we see so much, denying disability, right? Who does that benefit? Some disabled people really say, thank God you're not calling me disabled anymore. But the vast majority of people who are disabled don't really benefit from that denial. They want help. They're entitled to help. And if you say they're not really disabled, then what are they getting when they get help? They're getting something they don't deserve or need. That's crazy. Tell the truth. If you've got a handicap, a disability, or some impediment to being just as good or successful as the people you want to be like, get help. Get the support you need. And don't feel guilty about getting it. You need it, and you're entitled to it. One of the things I show staff and parents is that you climb a staircase when you're rendering treatment. There are no landings. So you see on the staircase as you climb it, what happens to the volume of work on either side of the staircase? It stays the same. But the caretaker's responsibility grows and the provider's responsibility diminishes. As you go up the staircase, as you proceed in treatment, that's what should happen. If the parent's role doesn't increase, you're not providing treatment, you're supporting a system that's pathological. I draw this diagram for parents before we start treating their kid. And the squiggle to the left of the grid is baseline. This is how the kid's functioning. The higher up on the grid, the worse it gets. So we start treatment, and after about a week, the kid says, "You in what effing army?" That's called an extinction burst, right, in the literature. I love using hyperbole, and someday I'm going to pay for it, I'm sure. But look, in the meantime, it's more entertaining than to be stuffy, right? Okay. After you get over the hump, and that's all it is. It's a hump. It's not a barrier. What happens, however, if it turns into a plateau? And we're seeing that the kid is 10, 10, 10. Whoa, wait a minute. Something's wrong. We have to go back to the drawing board. Well, we're taking outcome data from the parents every week. Now, what happens when a parent gets the question, well, Mrs. Jones, how did Johnny do today in school? And the parent looks at you with a straight face and says, how am I supposed to know? Ding! What's wrong with this equation? The parent has been convinced that they are not welcome in the school, they're not appreciated, they're not recognized, and we have to fix that mess immediately. All right, so we ask the parents on a week-to-week basis, how's your kid doing with the behavior that we've identified as a target? If he's physically aggressive, what do we mean by that? We operationally define it. He kicks, spits, and punches. Okay, fine. How frequently has Johnny kicked, spit, and punched in school this week? Because we're not treating him at home. His problems are in school. Now the parent has to tap that font of information and find out how frequently and how severely the kid's behavior has been going off the rails in school every single week, because we're going to ask. Just asking brings them more into the fold. So then the parent tells you, well, it's getting better, but it's, it's still up high. Okay, we're over the hump. It's going down. And as it goes down, then you'll see that little bump in the middle. That's called spontaneous recovery. That's when the kid realizes, hey, I didn't used to have to work this hard. And they want to go back to the way it used to be. We tell parents ahead of time, this is coming. You're going to see this. Don't be alarmed. Don't throw us out. Don't give up. Continue doing what used to work, and it will go away. And then sometime down and later on, you'll see an echo of it. But the bottom line is, over the time the treatment is rendered, that's what an effective treatment program looks like. Now, that can be 13 weeks or 13 years. Birth to 21. We have some kids we've worked with who are so profoundly impaired intellectually that their learning curve is glacial, right? It's just, so what's the solution? Flush them? No. We're going to work with them. We're going to help them learn skills. We had one kid that needed 2-on-1 staffing for 4 months before he stopped trying to take flesh out of the shoulders of the people who were working with him. 2-on-1, 20 hours a week. Can you imagine the fight we had to go through that one? But we won because we know the law. So now the kid doesn't bite anymore, and we've changed his life because now he's not going to get beaten up by his peers, his caretakers, for violent behavior because it's out of his repertoire now. And in some cases, you have to just swallow hard and say, maybe that's as much as we can do. And at some point you have to say, if we have entered the realm of spectating and there's no more active treatment going on, we have to say we're done and we wish the kid well in the future. And then if the things turn around and start going downhill again, we can go back. The kid's not 21 yet, and we can implement programs that used to be effective, etc., right? So that's the whole point. It's birth to 21, subject to the child's need. This is the first page of our treatment plan, and you'll get it in the handout so you can see it clearly. But you can see that it's a lengthy document. If this is just the first page, and this only talks about one of 3 behavioral domains that we're addressing, the first one here is inappropriate compliance with adult directives. Perhaps inadequate compliance would be a better way to put it, or non-compliance. Well, in fact, this child ignores adults' directives, uses negative comments when given a prompt, refuses to complete assigned tasks. They also have physical aggression and immature socialization skills. We have a hierarchy. If a child has physical aggression, that has to be addressed as its own behavioral focus, to the exclusion of other things. If there's physical aggression, we'll address it as an important thing to address. And physical aggression doesn't include kicking the wall or punching the wall, or throwing objects. But if you throw an object at a person, now it's physical aggression. So you have to separate and differentiate between who's the target. Now, if a kid punches himself, is that physical aggression? No. That's self-injurious behavior, and that's the second issue we always focus on, and it's called safety awareness. If a child's oblivious to vehicular traffic, this could be having a very bad end, right? So we focus on that as the second mandatory area in a kid's life, if it exists. The third mandatory area is non-compliance with adult prompts. If you're not even listening to the people who have the capacity to help you, you're doomed. So, physical aggression, safety awareness, non-compliance, those are the top three. The other two we focus on is communication. If there's inadequate communication skills, your life's not going to turn out very well. And the last, if it doesn't fit anywhere else, it fits in the realm of socialization. So that's the 5 items that we focus on for every child. We pick 3 out of that collection. We write a behavioral treatment plan that operationally defines the target area, and then in the objectives section it talks about what we're going to try to accomplish. And the goal, the long-term goal, is to improve the level of compliance and appropriateness of responses to adult directives, and we operationally define that as well. He listens or attends to directives without arguing, complies with one prompt, and tolerates redirection and limits without agitation. So it's a really explicit treatment plan, and there's 3 goals like that. We're talking about TSS at school, home, and community. Now here it says 12 months, 35 hours per week. I left that in there just so you'd see a real graphic example. This child's treatment program can legally be prescribed for 12 consecutive months at 35 hours per week. And that's a bachelor's level person in the home, in the school, 35 hours a week for 12 consecutive months. We also have a master's level person for 3 hours a week who is providing training, supervision, and oversight to the bachelor's level person. At the very bottom in the fine print it says, and I'll read this clearly so you hear it, TSS providers, and that is the bachelor's level person, can and should, underlined, work alone with the child. It is necessary and expected that TSS providers will deliver TSS services to the child both alone, with a nearby adult, and in the company of one or more adults who are responsible for the child, so that the child's learning process will be optimized. In other words, minimal distractions, consistent behavioral expectations, as the child's behavior patterns are being changed. The engagement of one or more adults responsible for the child, and that is working directly with the TSS provider, emulating the TSS provider, and implementing behavioral interventions in the absence of the TSS provider, is also required to support the delivery of behavioral health rehabilitation services. So this is a really comprehensive approach to behavioral treatment, and that's why it's funded under EPSDT, to the chagrin of those who wish it wouldn't be. If you look at the methods of achieving the objectives, you can see TSS, that's the bachelor's level person, and school staff will utilize positive reinforcement, reward systems, etc. They talk about these various behavioral interventions, and what we are now starting to add to our treatment plans are evidence-based kernels. Write that down, because these are some of the most brilliant insights that have ever been collected. And I keep talking about Dennis Embry and the Paxis Institute. Check that out, because he has created the greatest prevention model in the history of time. And if you talk to the Paxis Institute, P-A-X-I-S, you'll find a wealth of information there about how to do these prevention programs that are just astoundingly effective, all evidence-based. So we're bringing them into schools with our staff as well. Here are some more examples you can read off here. the TSS school staff and parents will utilize contingency contracting. That's basically, if you do this, then we give you that. And there are ways of implementing contingency contracts that are low cost or no cost, entertaining, and terrifically gratifying, especially to little kids. So the idea here is, if you set little kids on the right path, and if they have exposure to these sane, preventive, stabilizing things. For example, how many kids experience this? All right, let's pay attention. What does that sound like to some kids? How many times have I told, right? That's bad, as opposed to a gentle blow on a harmonica. And then they put their little hands up and make the peace sign. And this is called PAX, for the peaceful, healthful, happy. It's a brilliant concept. Check it out. All right, so our staff are implementing these kinds of little insights in the kids' lives. And as a result, the kids are going to display both target behavior and replacement behavior, and the staff are recording it. How many times in each hourly interval did the kids show inadequate safety awareness? Did they show positive safety awareness? In the bottom half of it, we have them circle the specific behavior that was displayed. And so we're doing bean counting. There's no doubt about it. There's a place for bean counting in the delivery of behavioral treatment. But that's not all we do. We're also measuring the average distance from the client during today's interventions. So how do you titrate services? Titrate means lessen, weaken, right? If you ask an insurance company inspector or a state Medicaid agency director, they're always going to say, well, you cut it back. You go from 20 to 10 to 5 and then stop. Well, what happens when you go from 20 to 10 and the kid has the inevitable bump in the road? You're not even there. So now what happens? The kid has to cope as best he can? Well, that's right. The school should do a better job. Oh, please. How does that make sense except in an absolute bureaucratic bean-counting way? Here's how you do transition and titration the right way. You're here with the child and you're doing 20 hours a week or 35. And as the kid gets better, you move farther away until the point where you're doing at the back of the classroom and the kid's hanging on. What happens if he has a meltdown? You zoom in and you save him. You recover. You don't lose any training or knowledge. You save the kid. That's literally what you're doing. You can't do that if some insurance company discarded you because you're not needed. And let's talk about the discarding process. You've got a kid with a history of behavioral difficulties. If you're sane, what will you predict the future to be like? It will be like the past, because the past is the best predictor of the future. That's all there is to it. So if, in the absence of behavioral support, the child would deteriorate, disintegrate, and fall into bad habits, what is the most appropriate prediction if you pull those supports away? If you're an insurance company, you're saying he's going to get better. What? It makes no sense. But that's what they do because that's what they're paid to do. You thwart that with honesty. And you say, look, the kid's behavior is this. Without the support we're providing, it had been this much worse. So therefore, we're going to withdraw the support sanely. We're going to move ourselves farther away from the child, first of all, and we're going to use a higher level of prompt. We're going to use physical prompting if we have to, but then we're going to go to verbal prompts. Then we're going to go to gestural prompts like, hey kid, we need a break. Let's go for a walk. And then we're going to have visual schedules, which are almost the antithesis of behavioral intervention. It's a reminder. So we're going to do that and make the kid get less and less service that way. And we're going to be farther and farther away from the child, and they'll get less service that way. And at the end of this time period, they're still getting 20 hours a week. Now, we don't do that forever because that's watching paint dry, right? So we then say the child has made reasonable goals. Sometimes we'll even, because sometimes parents get really over the top. You told me this was an entitlement. He's entitled to it, right? We have to cope with that too. It's not an entitlement if he doesn't need it. So we have to be able to say he doesn't need it. The staff was outside the room, maintained visual contact with him for a week, and now we're done. And nobody on earth can challenge that. Not an insurance company, not a county or state government, not a parent. And it's a way of rendering treatment that is clinically appropriate. The next page of the TSS progress note is that we actually collect information about antecedents. We record information about what the child's response to the treatment was and what the caregiver did in the process of our rendering treatment. We try to involve them in it. And then we tally up the totals from this page so we have a sense on a numeric basis, is the target behavior going up or is it going down? Now don't forget, this is the TSS, the service provider's record. Do we base our outcome opinions on this? Of course not. If I ask my staff, hey, how'd you do last week? What are they going to say? I did great, right? It's human nature. We all want to defend ourselves as, competent or excellent, even when we're not. So you don't ask your staff to be the basis for the determination of what the child's needs are. You ask the parent. And you ask the parent once a week, every week, Mrs. Jones, on a scale of 1 to 10, how frequently has Johnny displayed physical aggression as manifested in hitting, kicking, and punching in school? And they'll tell you, I guess it's about a 4. Well, last week you said, Mrs. Jones, it was a 6. Has it gotten better? I don't know. Why do you keep asking me every week? Because that is what's called a single subject with repeated measures experimental design. That is what allows us to collect data and put it on the table with the insurance company and say, look, you may have your opinion about the school's education program, the quality of his education, but your opinion doesn't matter at all. And in fact, Pennsylvania's Department of Public Welfare has published 3 times a statement that the Department of Public Welfare's insurance company people cannot quibble about the quality of a kid's education program because EPSDT funding is not education. It exists over top of education. So the insurance company may feel that the quality of the kid's education program actually sucks. You may agree. You may absolutely be convinced he needs a one-to-one classroom aide in order to get a free, appropriate public education. However, if the kid's parent and the kid's school say, it's just fine, you can't fight that. You're not a critique of the education system. You're trying to help the kid cope with it. And you're trying to help the parent understand, look, you got rights as a parent here. You don't have to sit still and wait for the education system to come around. You can take them to due process. And my staff routinely tell parents, look, your kid needs a one-to-one aide. We're not allowed to take him to the bathroom to be toileted unless he has some terror about the toilet and we're trying to help cope with his behavioral aversion or something like that. Your child needs a one-to-one aide, and we'll help you put things in place to have the due process hearing so that the school does what they're supposed to do. But until that happens, your kid still needs a one-to-one behavior support person, and we'll still prescribe it, and we'll still make sure he gets it. And we'll fight the insurance company to the extent that we have to win. But that doesn't mean your kid doesn't need behavioral support in the school, sponsored by the school. And here's the best part. Let's say the school finds a grandmother who needs some extra income. This is what typically does happen, right? Do our staff have to go away just because there's a grandmother working with the kids 6 hours a day or 4 hours or 1 hour? No. TSS, Therapeutic Staff Support, with a bachelor's degree, trained and supervised in behavioral treatment, can coexist with a one-to-one educational aid. A personal care assistant handles personal care. That's prescribed by a medical doctor. It's not behavioral treatment. But if we can convince the personal care assistant how to manage behavior better, then we are duplicating services and it's time to go away. But that's how it's supposed to work. Education is education, mental health is mental health, and you'll see an example of what I'm talking about shortly. If a kid needs 5 hours of treatment a week, I'm not going to prescribe 35. That's silly. But according to the National Academy of Sciences in 2001, a child with an autism spectrum disorder, and that includes symptoms of ADHD. Actually, ADHD and autism are more or less synonymous to the point where you can't diagnose ADHD and autism in the same child. If they have autism, it subsumes that they have ADHD. So, if the National Academy of Sciences, chartered by the U.S. Congress over 150 years ago to inform Congress on matters of science, if they, in 2001, say that a child with an autism spectrum disorder symptom picture needs 25 hours of intensive individualized treatment every week, including the summer, to have a reasonable probability of symptom abatement, and the American Academy of Pediatrics twice in 2007 and 2012 said the exact same thing. 25 hours of intensive individual treatment is the minimum necessary every week for a reasonable probability of symptom abatement. What happens when the insurance company comes in and offers 5? You just ask, do you read? Do you listen? I wrote in here, I cited those authorities in my prescription. I cited the EPSDT requirement for prevention and maintenance and treatment, and it's all in there. Did you read it? And really, you read it and you're ignoring it? Are you serious? I'll appeal it. And I'll appeal it. And I'll appeal it. And eventually it gets to the state Medicaid agency, and the secretary of the Department of Public Welfare says, I agree with what everybody else said. Really? Did you read it? Did you? Really? So what do? Pack it up and send it to Washington. And it keeps going and keeps going. And what happens is sometime somebody makes a phone call and says, I read it. Did you read it? We're the largest psychology practice in the state of Pennsylvania that treats children exclusively. So we're not in this superficially. We've been doing this for 20 years. And there are enemies out there. There are people who are trying to undercut us, but I hope that they aren't successful, and I'll do everything to preserve the rights of the kids we work with.
I have a question.
Yeah.
When you talk about filing your complaint within the Office of Civil Rights, is that the Office of Civil Rights within the Department of Justice or within both?
Within the Department of Justice.
Oh, okay. And then I also was wondering, does that can relate to what you're talking about as far as retaliation from funding sources, or my perception of that happening? Do you have any thoughts, and I'm not trying to get you off topic, but at some point, do you have any thoughts about how you prepare staff and work with staff if they're feeling nervous that because of stances you're taking, their job might be affected?
Well, I mean, the bottom line is my staff are acutely aware of what I'm doing, and that's why they come to us. We're getting applications from all over the country. People want to come and work with the Institute for a year, 2, 3, whatever. So we have no lack of people who want to work with us. You know, in the TSS realm, we're getting 30 and 40 applications a week. You know, so this is how popular this program could be in every state when you maintain this kind of fidelity to these high standards. Nobody can get this kind of training anywhere else, right? So they're going to come and they're going to work for 1 to 3 years, and the Institute is a training facility for new professionals. So we have an inexhaustible supply of talent that want to work here. Some of our staff have been with me for more than 10 years. You know, it's not like we throw them out because they've spoiled. You know, but honestly, when you stay in any place for more than a couple of years, you start to get stale. You start to get jaundiced, you know, cynical. You know, so I really want to turn over the ground, you know. Not that I want to get rid of good people, certainly, but I'm acutely aware of people becoming less, you know, they lose their edge. And I try to keep them, you know, up to date to the extent that I can, but we have extremely high standards for our staff, and that's why we have such a great body of professionals. This is the last page of the treatment collection sheet for TSS, and literally all they have to do is circle the intervention they used on this page. It comes directly out of the treatment plan. Now, I have the master's level mental health professionals looking at these sheets every week. And if they start to notice that a TSS is circling the same stuff over and over, you know, either the other stuff needs to be deleted because they've got the solution, or much more likely, it's not that they've got the solution, is that they've become complacent. So they keep the TSS on their toes by monitoring this every week. And in fact, the biggest area that we have for quality assurance is who's monitoring the master's level mental health professionals. Because when one of those people goes south, they can take down 6, 10, 15 people with them. And that's where we use an intermittent thing where you're going to look at her records and she's going to look at your records. And we shuffle them around no less than once a month. In the treatment plan, we have 4 mini plans. The first is a discharge plan. We actually plan ahead from the day we start working with the kid. What are we going to do when they're done? How do we know when they're done? And we set criteria, usually a score 2 or lower. Some kids are going to fight no matter what, but they're not going to draw blood. So if you add the frequency and the severity of a kid's behavior, you know, it's a frequency of 6 and it's a severity of 2, divide by, that's a 4. That's high, but it's not ridiculously high. That's what we're charting every week, the average of frequency and severity ratings, so that the parents can have their input, and they can see, as the kids' treatment program is developing, they can see exactly how it's working. We have a titration plan that I described where the staff are getting further and further away from the kid and using a higher and higher level of prompts in a hierarchy. We have a transition plan which is designed to replace all of our services with low-cost or no-cost replacements. If the kid can be enrolled in a situation with the YMCA at a greatly reduced rate where they have greater opportunities for socialization, that's a good thing. Or they can begin to participate in their own church's activities again. The church youth group is very often one of the most hospitable environments that a kid can go to, but unfortunately churches, the last survey I saw, showed that 20% of churches are actively supporting families where there's mental illness in the household. And that's a real tragedy. Mental illness is way more than just 20%. And so the youth groups may not be a viable solution, but it should be investigated. And who's to say that a kid who is Jewish can't go to the Presbyterian church's youth group? More often than not, the youth groups, if they are following a Judeo-Christian tradition at all, or a Buddhist tradition, or any other kind of tradition, they're going to welcome people with exceptionalities, especially if they're having one of the staff go with them, right? So we try to do transition as much as possible. And then finally, we have a crisis and emergency plan for every kid. We always have a staircase. At the top of the staircase is 911. If a kid is so out of control and dangerous, for damn sure we want to involve the local law enforcement people to help that kid realize that they're not the end of the line, they don't have the last word, and in fact the cops will come if they're summoned by the parents or somebody else. When we do services in a school, we have provisions for in-school services. The schools have to be reassured that we're not asking them to fund it. We're asking them to make it possible for the child to get one-to-one behavioral support in their domain. Just make the classroom accessible to us and we'll take it from there. What happens when the child goes to school and the TSS doesn't show up? They're sick. What happens? Can the school take the kid and say, oh no, 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 go home. You can't come to school today. Can they do that? No, that's a violation of federal law. That's a deprivation, denial of FAPE, a free appropriate public education. So the school has to have a contingency plan in place. Now sometimes one of my master's level mental health professionals shows up and acts like a TSS. And I pay him at the TSS rate, which is lower. And they do it willingly because they get a chance to spend 6-7 hours with the kid and really understand how life is for the TSS, which is a good thing for them since they supervise the TSS. And just so you understand, Pennsylvania's pay rates for these services were set in 1992, 22 years ago, and have never been changed. No cost of living, nothing. A TSS, a bachelor's level person, I can bill about $30 an hour. Now I pay them $15 to $16 an hour. I offer them health insurance if they work more than 30 hours a week. They get the training, the supervision, because most of the TSS are actually in graduate school getting ready to be master's level people. The master's level people I can bill for about $49 an hour. And they can do that until they get licensed, in which case then I pay the psychologists $50 an hour, up to $75 depending on what they're doing. So I'm making this go in Pennsylvania with pay rates that are 1992-ish. So I guarantee in your states, Jersey for example, they're paying TSS level people at least $45 an hour. I could make it work for $30. So we go into the school, we have them sign off on this, we explain to them that in the event that the TSS doesn't show up, the school has to rise to the occasion, move the kid in with the guidance counselor or principal or something, provide support, and more often than not, those occurrences are rare, so that my staff are reliable, predictable, they know what's at stake if they don't show up. All right, this is a spider web, and you see in the very center BSC, Behavior Specialist Consultant. These are the lead clinicians in my model. They have master's degrees, they've got at least a year of experience working with kids, and they connect with the office staff, of course, but they connect with parents, grandparents, siblings, children, other BSCs, TSS, school authorities, MTs, psychiatrists, physicians, and you can go around the ring. In other words, the BSC is involved in an absolute wraparound way with these kids. And in a psychologist's practice, as an independent practitioner, a BSC can do all this. In other organizations where you have a community mental health center, they hire case managers to do a lot of these contacts. So you got a case manager doing their thing over here, and you got a clinician doing their thing over here, and sometimes those people don't even know each other's name. You know, that's a tragedy, because unless you do the wraparound thing and integrate these various people, the kid's getting supervised, monitored. You know, they're not getting treated. It's wraparound. It's high fidelity wraparound, but there's no treatment. We implement what's called the CASP principles, and the CASP stands for Child and Adolescent Service System Program. And it's a series of standards. It's actually part of the Pennsylvania regulations, where services have to be child-centered and family-focused. They have to be least restrictive, least intrusive, culturally competent, and have to involve multiple systems if multiple systems are involved in the kid's life. If juvenile justice is involved, if substance abuse, children and youth, foster care, everybody gets involved in the contribution to the kid's treatment program. And we have a checklist that monitors the extent to which that's been happening. Like I said, we take behavior on a weekly basis. This is a snippet of that. We take frequency and severity data, and then we plot it on a graph. Here's one graph. That's a significant improvement after the implementation of TSS services. And we're talking about TSS services that are delivered every week for 30 hours a week. Here's a more dramatic example where we're taking data and it's working out really well. Here's another presentation of the same data. And in the white brochure, you'll see the results of studies at the University of North Carolina at Chapel Hill and Thomas Jefferson University, where they studied the outcome of our treatment process. And they said, we can't say your process caused these effects because there's no control group. But wait a minute, there's over 1,000 treatment records, 75 to 85% showed improvement in 4 months. And the improvement continued over the year. So of course we can't claim that we did anything, but hell, there's 1,000 of them. And the really amazing part is that the probability of those results occurring due to chance is less than 1 in 10,000. A normal standard for a publication in a journal is 5 in 100. That's a significant finding. In other words, our ongoing research is happening. We've got 90% completing treatment in 3 years or less. In one study we recently did, we looked at 53 treatment plans selected at random. We had cases where there were no TSS involved, and then TSS was delivered, and then TSS stopped for one or another reason. Average treatment term was 1.4 years. There was no difference between the kids with autism, ADHD, other diagnoses, genders, or ethnicities. Everybody got better in regard to physical aggression, safety awareness failures, non-compliance with prompts, communication deficits, and socialization deficits. This is the best treatment modality ever created for children. The best thing about it also is there's no halo effect. In other words, the kids didn't miraculously become better as soon as my staff showed up. And in fact, wait for it, the extinction burst means they actually got worse for a little while. And by the same token, when treatment stopped, they didn't immediately crash. There was some learning that had taken place. Now, after 4 weeks, things started to go off the rails, like you would expect. Our most recent research, 75% of the families were below poverty. Ages were 3 to 18, 84% males, no surprise there. 189 kids, 63% were white, 20% African American. A total of 519 treatment plans were analyzed, and treatment periods lasted for as little as 28 days to 6 years. 52% had autism, 28% had ADHD. This is the quality of research we're doing, and the outcome data is this. Overall improvement in all categories with a probability of the results attributable to chance less than 1 in 10,000. Gender, family income, all made no difference. Children with autism, ADHD, and impulse control disorders had the greatest improvements. BHRS was not helpful if very low levels were delivered. The sum total of my presentation is you cannot drive a tack with a toothpick. You don't use a sledgehammer. But if the insurance company says when a kid needs 25 hours a week, if those people say he needs 5, that's a toothpick. Children respond individually to individualized treatment. A kid who needs 30 hours and gets it is going to get better, 85% probability. A kid who needs 5 hours and gets it is going to get better, 85% probability. A kid who needs 30 and gets 10 is probably not going to get better. It's a toothpick. Over 15 hours of BHRS a week did result in greater improvements in communication skills for kids with autism. Goes without saying, if you practice it, sooner or later you get better at it. Longer BHRS terms resulted in greater improvements in physical aggression. Physical aggression is a tough nut to crack. If it exists in a kid's repertoire, you have to work really hard to get it out. The sooner the better. And that's why it's the #1 intervention that we go after. If you Google treatmentplans.work.com, it's the #1 information source worldwide for treatment plans for children. It's a great resource. I think you should just check it out. I have some sample plans you can use for nothing. I want you to consider the benefits of implementing a BHRS program for kids that #1 is supervised closely by licensed mental health professionals. We're not talking about a children's mental health center where the psychiatrist shows up once a year to sign the lease. We're talking about a licensed psychologist taking responsibility, professional ethical responsibility for the oversight of a real treatment program. I'm also talking about writing treatment goals that are objective, measurable, and school aware. You can't do a school treatment program that's oblivious to the needs of the kid's school. You have to use evidence-based practices, including the wraparound model, and you have to take outcome data from the recipients of services or their teachers or parents, not just your own staff, and you have to show improvement is occurring in the child's behavior over time. Now, you can legitimately defend an EPSDT funding plan to maintain a child's functioning. But at some point, you have to separate from the child and see if it would be maintained without you being there. And if it can be, then you can discontinue it honestly. So, what should you do when you discover that access to medically necessary treatment is being systematically denied to children with disabilities enrolled in Medicaid, which is a violation of their civil rights by insurance companies and county government and state government? For example, when they announce that they are planning to pay providers more if they prescribe less, and paying them less if they prescribe too much. Too much is over 5 hours a week. If they require that all evaluations are done by prescribers who all agree to prescribe less. What happens if you have this little cadre of prescribers that everybody has to go to, and every single one of those people prescribe 5 hours a week? What's wrong with this equation? 25's the minimum, son. How can you prescribe 5? What are you reading? They penalize providers that deliver too much treatment, even though it meets the Department of Public Welfare, the National Academy of Sciences, and the American Academy of Pediatric Standards, and is well documented. You penalize them by hyper-scrutinizing their treatment record. If the state Medicaid agency refuses to establish or enforce standards for what insurance companies are supposed to use in determining what is medically necessary treatment, do you know what the insurance companies in Pennsylvania are saying when providers say, wait a minute, you're telling me all of the services have to be done face-to-face? I can't write a treatment plan in my office and deliver it to the family? Where does it say that? The fact is, it doesn't say that anywhere. That's a quality standard that the insurance company is implementing. But wait a minute, does that quality standard impede access to treatment? Of course it does. I'm going to have to sit on a kitchen table and write a treatment plan where things are coming apart? That's crazy. but that's how you're going to force me to do it? That's an impediment to treatment, and that's the stuff that the Office for Civil Rights really has a problem with. And finally, refusing to answer provider policy questions. If you're a licensed professional and you're aware of abuses of civil rights, you're supposed to file a complaint even if none of the advocacy groups help, even if none of the lawyers help, because that's what you're required to do as a licensed professional service provider. And when you do that, you can do it online. No lawyer involved. Go to the Office for Civil Rights website, fill out the form, and send it. You can send it electronically. You can attach exhibits. That's exactly what I did. And when you look online, it says they are a federal enforcement agency that investigates complaints, enforces rights, promulgates regulations, develops policy, and provides technical assistance and public education to ensure understanding of and compliance with non-discrimination and health information privacy laws. That's what the Office for Civil Rights does. Do they represent you in a civil rights complaint? No, they do not. And let me correct the record in case any internet jackass thinks I'm practicing law without a license. I'm not a lawyer. I'm not giving legal advice. I'm giving information. All right, just like the Office for Civil Rights. They are a neutral fact-finding agency. Their charge is to ensure that the laws under their jurisdiction are not violated. One of the things under their jurisdiction is Medicaid. If there is a violation of the Medicaid Act, in that children are not getting services that are sufficient in amount, duration, and scope to reasonably achieve the purpose for which they are furnished, that is a violation of civil rights. And that's why the Office for Civil Rights has to investigate it. It's not an option, it's a necessity. Although we will consult with you, you may not be satisfied with any individual remedies proposed. Now, that's true. They could keep this investigation going for the next 1,000 years and never come to a conclusion about it. That's their prerogative as the Office for Civil Rights. And you should consult an attorney about your right to file a private lawsuit in court if you want to protect fully your individual rights and remedies. That goes without saying. So once it's clear that the Office for Civil Rights has jurisdiction to handle your complaint, the investigator will gather information through interviewing witnesses, obtaining documentation, and making visits to appropriate sites. You may be interviewed again and can submit additional evidence as information is gathered. There's an open claim at the Office for Civil Rights that I'm continually sending them information. And it just gets worse and worse and worse and worse with every new document that they get from the state's perspective. Now, I don't know how this is going to come out. If the Office for Civil Rights says, nope, they're doing everything just fine, we can imagine what the Department of Public Welfare is going to do in Pennsylvania. I mean, they'll just redouble the efforts that they're already making. I honestly don't think that's likely. The Office for Civil Rights would not have opened an official investigation after a year of evidence collection unless they had reason to believe that there was a probable violation. As you see down here, it says file a civil rights complaint. That's what you click on. And when you do, this is the form you get. And this is exactly what I complained. I said, disabled children enrolled in Medicaid in Pennsylvania who are prescribed BHRS treatment under EPSDT of the Medicaid Act that meets all of the criteria of the definition for medically necessary treatment, and I cite the Pennsylvania law that describes it, are denied funding by behavioral health managed care organizations and the Pennsylvania Department of Public Welfare, who claim that the prescribed services are not medically necessary. You could write the same thing in your state. And then I further said that the Behavioral Health Managed Care Organization and Department of Public Welfare denials are not consistent with the definition of medically necessary treatment and violate the civil rights of disabled Pennsylvania children by denying EPSDT funding for the treatment of their disabilities by this and other means. And I attached a slew of documentation that supported that claim. And again, there is the Pennsylvania definition of medically necessary treatment, and you have to understand that that is different from state to state. So let me finish up while you're scoring me. In the United States Federal Court in Illinois, the Eastern Division, there was a lawsuit filed because kids were not getting their EPSDT entitlement, and the court certified that a class of people existed, all Medicaid-eligible children under the age of 21 in Illinois who have been diagnosed with a mental health or behavioral disorder and for whom a licensed practitioner of the healing arts has recommended intensive home and community-based services to correct or ameliorate their disorders. They're a class in a federal lawsuit. That suit's going to get EPSDT services into Illinois in a big way. The Center for Medicare and Medicaid Services issued a policy clarification on July 7th in which they say in writing the principle of statewide-ness applies to EPSDT funding. I saw that, so I wrote a letter to the CMS, to Cindy Mann, and said, hey, how can you have the principle of statewide-ness if these characters are over here are mandated evaluators and these characters over here aren't, and these guys demand that all the services have to be delivered face-to-face and those guys don't have to? It's just crazy. You have insurance companies making state policy and enforcing it, and the State Department of Public Welfare is sitting there saying, well, you know, that's their quality assurance standards. We aren't going to quibble about that. Are you kidding? Is that legal? And last but not least, the National Health Law Program, in October, just a month ago, issued a brief talking about the new California law. The new California law required the state to cover BHT in Medi-Cal when required to do so by federal law. What's BHT? It's behavioral health treatment. Wait a minute. EPSDT talked about that in '67. So now, in June of 2012, Medi-Cal is identified as coming into the United States of America. Are you kidding? Better late than never, you know? So thank you for your time, patience, and attention. I did it.